Today I'd like to talk about pediatric transport. Before we transport any of these patients, we need to make sure we have permission to transfer them. There are a lot of different methods to make sure we cover each of the points and make sure proper exchange of information has taken place. One of them is the IS-BARC method. It's introduction, situation, background, assessment, recommendations, followed up by questions which can be asked for clarification. We need to make sure we have enough supplies. This is manpower. We need to make sure that at least 2 care providers are available, not to mention a driver and pilot. We also need adequate supplies to take care of the child. We need the equipment, the medications. Really important is monitors. We need a lot of monitors, more the merrier, because the physical exam is very different in the back of an ambulance or in the air. These monitors can help detect physical changes that can't be detected otherwise. We also need to prepare the patient prior to transport. We need to anticipate deterioration. What's going to happen if this patient starts having respiratory distress or requires fluids or something else like that? We need to think of things that can happen and perform those necessary procedures or obtain that necessary equipment or give those necessary medications prior to being in the middle of transport. We need to assess the patient prior to transport to make sure we take care of them as best they can prior, and then monitor them correctly during transport. The pediatric assessment triangle is a quick and dirty way to think of, really, is this patient sick or not sick? The stable mnemonic is something I think we really can focus on and remember. I'm not huge on mnemonics. I can't remember them very well, but this one is actually really helpful. Stable mnemonic stands for sugar, temperature, airway, blood pressure, laboratory values, and emotional support. Sugar, we're going to talk about these a little more later because this is very helpful in remembering certain things that we need to keep in mind when transporting, especially neonates. Sugar, we want to maintain the blood glucose at 50 milligrams per deciliter. Temperature, normal neonatal or infant temperature is between 36.5 and 37.5 degrees Celsius. We need to make sure these patients have a good airway, that they're ventilating well, that they're getting the required oxygen. Obviously, there's no way we can assess for adequate perfusion. There are things that we look at, but make sure that they've got a good pulse ox. We need to make sure their blood pressure is maintained. Kind of a typical neonatal blood pressure is between 46 and 60 systolic and 25 and 35 diastolic. Laboratory values. Check the laboratory values prior to transport. Obviously, we're not going to do screening laboratory results, but check the necessary labs. The last is emotional support. This is probably something that can be easily looked over, but means so much to these patients. With infants and neonates, there are going to be some real key things to think about in intubation and ventilation. The purposes of intubation are no different than in adults. We want to prevent obstruction, ensure ventilation, provide oxygenation. So the threshold to intubate kids who are going to be transported is going to be a little lower because there is a higher rate of failure in intubating children and especially neonates and infants than adults. So we need to make sure that if we think they might deteriorate, we probably need to tube them before they are transferred. If we didn't do the intubation, so if we are receiving a patient from the field, make sure that tube is in the right place. Check and recheck. Direct visualization, auscultation, end-tidal CO2, chest x-ray, ultrasound. All of these things can help make sure that tube is in the right place. Make sure it's secured properly. If the tube is too deep, it can be easily right main stemmed. This is going to place the patient at a higher risk for pneumothorax, and it's going to impede surfactant administration if that's something that's needed. Also remember that intubating kids is very different. They have anatomical differences that we need to keep in mind. Their trachea is going to be higher and more anterior than in adults, and we need to keep that in mind. We'll talk about that a little more in upcoming chapters. DOPE is a mnemonic to think about when we are having trouble with intubation or having trouble especially with ventilation. So displacement, make sure that the tube is not displaced. O stands for oxygen, make sure the oxygen system is not faulty. P is for pneumothorax, has the patient received a pneumothorax after we've started bagging them. E is for equipment failure, is the vent working? If it's not take the patient off the vent and bag them. Ventilation settings for neonates, pediatric patients. I don't want to delve too deep into ventilator settings because we have resources that are available to help us remember all of these nitty-gritty details. PEEP is going to help recruit alveoli. Term neonates typically need pressure-controlled and inspiratory time managed settings. Infants and children are typically going to be volume controlled with SIMV mode. We're going to use typically between 8 and 10 milliliters per kilogram. Both neonates and children, infants, are going to need PEEP. If we want to increase ventilation, we typically need to remember that to do this, we're going to increase the rate of ventilation and the pressure support. If we want to increase oxygenation, that means we need to recruit more alveoli. So increasing PEEP or increasing the FiO2 can help increase your oxygenating capacity. With IVs in transport, we need to really make sure that these critically ill kids have at least 2 IVs. If one goes bad, if we need to administer more than one medication that can't go through the IV, these are important things to remember. We also want to make sure that we're not starting IVs on kids that the IV start is going to make the patient more unstable and worse. That's something like epiglottitis, where any anxiety and crying could potentially make the patient much sicker. Also remember that pumps are going to be more important in the pediatric patients. We can't typically give a big bolus of fluid by hanging a bag. We need to make sure that we're giving the patient a very weight-based dose of fluid. Other neonatal issues to keep in mind during transport is kind of going back to that stable mnemonic. We'll cover that real quick. Sugar, temperature, airway, blood pressure, lab values, and the emotional support of the family. Hypoglycemia, this is the most common metabolic abnormality in newborn patients. At birth, glucose levels are going to be about 60 to 70% of the mother's glucose level at birth, and then fall in the next 1 to 2 hours to about 40. All neonates should receive some glucose prior to transport, and then we want to maintain this glucose at 50 milligrams per deciliter. Hypothermia can be a common issue, especially in these really early premature neonates. The goal temperature is 36.5 to 37.5. Make sure you have the equipment in your transport to do so. Do you have an incubator, something to warm the patient and keep them warm while they're transported? When patients have ROSC after an arrest, induced hypothermia is recommended. So the temperature that is kind of targeted for this is 33.5 degrees Celsius for within the first 6 hours of birth. Hypoxemia is a really significant and common problem that can occur in these neonates. If they're hypoxic, try room air first with some positive pressure ventilation. If that's not working, then try some supplemental oxygen using an O2 blender. We're going to talk a little bit more about neonatal resuscitation in the next chapters, but this is just kind of some basics to keep in mind. If a premature infant is less than 32 weeks old, start with FiO2 of between 30 and 90%. Remember that over-oxygenating these neonates can cause retinal and pulmonary toxicity, so be really careful with this. With these patients that are hypoxemic, ABG can be very helpful, but a venous or capillary blood gas can also be used to measure the blood gases. Keep in mind that a pulse ox and an ABG aren't really going to measure tissue perfusion, so use these as a guide. Respiratory distress in these patients is usually caused by not enough surfactant due to immature lungs not producing that surfactant. You'll do a chest x-ray, it's going to show some ground glass opacities, air bronchograms. Initial therapy is to provide positive pressure ventilation. Keep in mind that we want to avoid any negative pressure. I like to think of this as kind of a bubblegum bubble. You blow up a bubblegum bubble, think of it as an alveoli, and that bubblegum bubble is just fine. When you suck in and close that bubblegum bubble up, can you blow it up? No, not usually. If you can imagine that bubblegum bubble inside coated with a layer of oil or kind of slippery material, it wouldn't stick together. It would blow right back up. And this is similar to that surfactant. So Surfactant can be administered through an endotracheal tube, and we can cover that a little bit more later. If intubated, give the patient PEEP between 4 and 5. If they're not intubated, you can administer positive pressure ventilation by nasal cannula. Persistent pulmonary hypertension can happen as well in these neonatal patients. The anatomic changes that happen at birth, the chest wall expands, causing the lungs to expand and opening all that vascular space. This is decreasing that pulmonary vascular resistance. So now instead of shunting blood past the lungs and through the ductus arteriosus, it goes through the lungs to the left heart and through the rest of the body. If the lungs aren't opening up because of meconium or the patient's septic or for whatever reason, the lungs and the pulmonary vascular resistance isn't decreasing, you're going to have issues here. If you want to evaluate for shunting, you place the pulse ox in a preductal location. So this is before that ductus arteriosus. So think the right hand, place a pulse ox on the right hand, and then on a postductal place location, think one of the feet. That's going to be a postductal location. If there's a greater than 10% difference between them, this suggests some shunting. If conventional intubation, correction of any metabolic issues, infection, etc. isn't working, then you can consider ECMO. For congenital heart disease, we're going to talk about this a lot more later, and all the very specific things related to congenital heart disease. Really, the things we need to remember now are that we initially give supportive management and then prostaglandin E1 to keep that ductus open. Remember that hypotension in neonates is anything below 60 systolic. If they're hypovolemic, give them a bolus of 10 milliliters per kilogram. Infection in these patients, we need to give really an initial meningitic dose of ampicillin and gentamicin. Inborn errors of metabolism are very difficult to remember. I definitely do not remember all of them, and probably very few of them from medical school. But bottom line is that they cause less ATP to be produced and accumulating toxic metabolites in the process. Really, they're going to have nonspecific symptoms, nausea, vomiting, lethargy. Fortunately, the treatment, though, is very similar for all of these. Stop feeding the patient. That's going to stop the production of all these toxic metabolites. Provide 10% dextrose in normal saline at 5 mils per kilogram per hour and facilitate removal of the metabolites. Lastly, we want to talk about viability of newborns. Before you start any resuscitation, we always need to think, gosh, is this really justified? Do not consider transport or resuscitation if the patient is less than 23 weeks gestation, or some, I guess, are doing 22 weeks. If the patient has a weight of less than 400 grams, or if they have gelatinous or translucent skin, all these are not consistent with survival. It's also acceptable to terminate resuscitation if no detectable heart rate is present after 10 minutes of resuscitation.